96. Okay, thank you. Question 96 says, Mr. Millsap is one of your outstanding clinic patients who has a history of rheumatic heart disease. His last echocardiogram noted a mean mitral valve gradient of 11 millimeters on a calculated valve area of 1.3 centimeters square at a heart rate of 60 beats per minute. He presents today complaining of worsening shortness of breath, and his ECG shows atrial fibrillation at a rate of 60 beats per minute. He has never had any bleeding episodes and had normal hematologic counts on his last check 2 weeks earlier. Which of the following options for thromboembolic prophylaxis is appropriate? So A, apixaban, B, dabigatran, C, rivaroxaban, D, warfarin, and E, more information is needed prior to initiating thromboembolic prophylaxis. Okay, basically the summary of the question is giving thromboembolic prophylaxis to a patient with valvular AF. So based on guidelines, we know that for valvular AF, warfarin is still preferred, and also patients who are on mechanical valves. Then for the other cases, the NOACs are preferred. So for this question, option D, which is warfarin, is the correct answer. Option E is out of place. I think there's enough information to start thromboembolic prophylaxis. So if there are other contributions, we can take that, and else we go to question 97.
Okay, just to add on, I think that's the Inventus trial where they noticed that warfarin has anti-inflammatory properties. So that's why it's actually preferred used for patients with valvular AF. It has an anti-inflammatory property. So that's why it's most preferred in the Inventus trial that was carried out. Thank you.
Okay, thank you. So question 97. All of the following are risk factors for development of pericardium cardiomyopathy except. So we're looking for the one that is not a risk factor. So A, advanced maternal age, B, malnutrition, C, primary paras, D, twin pregnancy, and E, use of tocolytics. Well, this question, somehow, all the options are actually risk factors, especially advanced maternal age, even young maternal age less than 20 years, especially from the presentation yesterday. I didn't really get it, but I was able to get just the screenshot. And then from the peace trial, I think this primary paras is part of the risk factors because young maternal age less than 20 years is part of the risk factors. Others are unemployment, poor socioeconomic status, preeclampsia, etc., multiple gestation, and all that. Although the answer for this one was option C. So I don't know. I was a bit confused anyway, but That was the answer that was chosen. But I know all of these are risk factors, so I don't know if it's is not in this Caucasian setting where this question is coming from. So I don't know if there are other contributions, but the answer here was primary parus, which was kind of contradictory to our own data.
Okay, so but between the multiparous and the primary parous, which patients do we have it more in? Hello,
The
Dr.
data,
Jenny.
the data from our environment has demonstrated that there is no prevalence in multiparous. Going by the that textbook that Prof just edited now, the data and environment have shown that there is no prevalence of what's it called, pericardium cardiomyopathy in multiparous women. Thank you. But I don't know about these tocolytics, they wrote here anyway.
So maybe let me just say one or two things so that we can move on. As
Mm.
against what we have in our local data, this book is not is from the Western, this book. And what we used to know, even way back, medical school and in all those developed worlds, advanced age, twin gestation, use of tocolytics, you understand, used to be like the part of the risk factors, common risk factors that we knew then for peripartial cardiomyopathy. But Karaye et al. And some other people have actually studied the peace registry and everything is coming up to say that since we have the highest prevalence and we're able to pull more data than in developed world, and we've actually really studied. So in our environment, most of our patients are usually parus. That means it occurs during their first pregnancy, and that's why we usually have issues with telling them not to get pregnant again, and they will keep getting pregnant and coming back. Do you get? Then all these other things like use of tocolytics is not really an issue in our environment. The only thing that might be maybe similar in the two might be the issue of hypertension and preeclampsia, which is we also see in our patients, although not as significant as malnutrition, younger age, low socioeconomic status, all the things that we have mentioned before. So we are answering this question based on the fact or by the data that they have in their environment. Thank you.
Okay. Thank you, Chief. Thank you so much for the contributions. So, question 98 is said you are evaluating a new patient in clinic. The 25-year-old patient was diagnosed with heart failure in another state and has since relocated. He has New York Heart Association class 2 symptoms and denies angina. He presents for evaluation and management. On review of systems, the patient has been wheelchair bound for many years and has severe scoliosis. He has no family history of hyperlipidemia. His physical examination is notable for bilateral lung crackles, an S3, and no cyanosis. An ECG is obtained in clinic and shows tall RA in V1, V2 with deep QS in V5 and V6. And his echo reports severe global left ventricular dysfunction and reduced ejection fraction. What is the most likely diagnosis? So a young patient in heart failure that doesn't have hyperlipidemia, has been on a wheelchair and has spine deformity and is having abnormal ECG findings, tall R wave in septal leads and deep QS in lateral leads, and then echo showing poor reduced ejection fraction, and global left ventricular severe global left ventricular dysfunction. So the options are saying A, amyotrophic lateral sclerosis, atrial septal defects, then chronic thromboembolic disease, D, Duchenne muscular dystrophy, and E, ischemic cardiomyopathy. I think from the questions, they're already from the history, they're already kind of ruling out some of the options. Like in A is said not to really have effects on the heart because it's a motor neuron disease. Then for ASD, there's really nothing pointing towards that. They're not saying anything about emissions or anything related to that. Then chronic thromboembolic disease, at least they would have mentioned maybe some complications or maybe DVT or something related to pulmonary embolism and all that. Then for Duchenne muscular dystrophy, it's almost more in keeping with this history, especially the typical ECG findings. And then the patient is having scoliosis and they are saying has been wheelchair bound. So they typically have scoliosis, especially when they've been immobile for a long time. So that fits into the history. And then their symptoms present at about earlier than even this age. And then they have typical ECG findings of a right ventricular hypertrophy. And there are some other ECG findings as well, not just the ones here. So I think they can also have pathologic key waves, not only in the also in the lead 1, 2, 3, that's in the link links as well. And then increase arrow wave amplitudes, even from V4 through V6. Then, of course, typical right ventricular hypertrophy. And then they can also have ST segment changes and T-wave inversion abnormalities as well. Sometimes they can present with short PRA interval and then sinus tachycardia, even prolonged QTC, and then ST depression. Other ECG findings in these patients. Then for option E, which is ischemic cardiomyopathy, there's really no history of maybe chest pain or and here they are also saying no history or denies history of hyperlipidemia and all that. But typically the history points towards Duchenne muscular dystrophy. So the answer is most likely option D, which is DMD. So if there are any other contributions to the, I'll kindly observe and then or we move to question 99. Okay, so for question 99, it says, which of the following is the most common inheritance pattern for familial cardiomyopathies? A is saying autosomal dominant driven by exon duplication. B, autosomal dominant driven by missense mutation. C, autosomal recessive driven by exon deletion. D, autosomal recessive driven by exon duplication. And E, X-linked driven by exon deletion. Well, for cardiomyopathies generally, the most common form of inheritance pattern is usually autosomal dominant. And it said that both recessive and X-linked inheritance can occur, but they are rare. So I believe that leaves us with option A and B. So with further investigation, it was noted that option B is the correct answer. That's the missense mutation is the most common inheritance pattern for familial cardiomyopathies. So, which is an autosomal dominant. So that's what I saw for 99. That's question 99. That occurs in DCM hypertrophic cardiomyopathy as well. So I don't know if someone else can explain this better, but that's what I found. That usually autosomal dominant, and then there's this missense mutation, like a substitution of an amino acid, something like that, in the inheritance pattern. Okay, so question 100 is saying a 45-year-old man with a history of obesity presents to the emergency department with dyspnea, fatigue, and nocturnal cough that has been worsening for the past several months. He denies any chest pain or pressure at rest or with exertion. On evaluation, he has evidence of cardiomegaly with a displaced apex, that's point of maximal, what they call it, PMI. PMI is points of maximal impulse, which is the apex, yeah, and elevated filling pressures with bilateral pulmonary rails and elevated JVP. Echo shows globally depressed left ventricular ejection fraction, 25%, with dilated left ventricle. Which of the following tests is a level 1 recommendation for further workup? Okay, so the patient probably has a cardiomyopathy and is in heart failure, HFrEF, and they're asking for which investigations fall into level 1. So A is cardiac MRI, B, coronary angiography, C, erythrocyte sedimentation rate, D, serum iron and transferrin saturation, and then E, thyroid stimulating hormone levels. So looking at all this, well, depending on the cause of the heart failure, each of these investigations may be relevant. But for level 1 recommendation, I think it's ACC-AHA or so. Level 1 recommendation in these options is just thyroid stimulating hormone level. But all these investigations may be necessary depending on the cause of heart failure. Like, of course, if you're thinking of hemosiderosis, hemochromatosis or so, you may want to do serum iron and transferrin saturation. And then apart from the thyroid stimulating hormones, other investigations that were under level 1 recommendation included chest radiograph, then echocardiography, ECG, electrocardiography, then serum EUCR, that's kidney function test, so serum potassium, calcium, magnesium, inclusive of urea and creatinine. Then there was also full blood count was under level 1, and then liver function tests. So those were the other investigations with the thyroid stimulating hormone. I didn't see others in these options, even though they may be required for required investigations in patients with heart failure. So I don't know if there's any update to that level 1 recommendation currently. I didn't see that, but the answer to this question is option E, which is thyroid stimulating hormone. Thank you.
Okay, thank you.
Yeah.
Okay.
That brings the end to my session of questions and to answer. Thank you.
Thank you so much, Dr. Finine, for taking your part. We appreciate your efforts. All right, so the next person on the list is Dr. Okedara, but I'm not seeing her on the call right now. I don't know, Dr. Conte, you're the backup. Are you ready for that?
Yeah. Okay, we can continue. So it's 101, right?
Yes. Thank you.
All right. So it says a 22-year-old college student with no past medical history was seen in the urgent care clinic 3 days ago for coryza, myalgias, cough, and fever, which was typical of the viral upper respiratory illness making its way through the campus. He was given a cough suppressant and antipyretics and advised to remain hydrated. Today, he presents to the emergency department with lethargy and fatigue. He is obtunded with a heart rate of 120 beats per minute and blood pressure of 78/62. His extremities are cold and jugular venous pulse is elevated nearly to the mandible. Precordial auscultation revealed very quiet heart sounds, an S3 gallop, and a soft murmur of mitral regurgitation. Emergent transthoracic echocardiogram showed no pericardial effusion, a non-dilated left ventricle with an ejection fraction of 30%, and mild mitral regurgitation. Endomyocardial biopsy shows lymphocytic myocarditis. Which of the following statements regarding this patient's prognosis and implication for therapy are true? Okay. So basically the scenario is patient is almost in shock. It's in shock. The BP of 70, 60, 62, and then having features of myocarditis. And the biopsy shows lymphocytic myocarditis. So basically, this one is having a fulminant myocarditis, okay, with very rapid deterioration and going into cardiogenic shock. So his chances of survival is less than 10% without cardiac transplantation. Emergent transplant listing is warranted. B, his chance of survival is greater than 50%, with many similar patients having a full recovery in left ventricular function over the ensuing weeks to months. Aggressive pharmacological and mechanical hemodynamic support is warranted. So, well, you have to do aggressive management, but this 50% survival, I think, is too much for this patient. C, immunosuppression with high-dose systemic steroid will increase his chance of survival. In myocarditis, they have not really been shown to be, effect to improve survival, given steroids. The presence and titer of anti-heart antibodies can help provide prognostic information for this patient. I don't think so. Most times with the viral-associated myocarditis, it's usually a direct effect of the virus on the myocardium rather than antibody-mediated. So for this question, I think the survival, because this one is fulminant myocarditis, prognosis is poor, and I think they should be listing such patient for transplant. So if this high survival was not in the B option, the B option can also be two. You manage aggressively with mechanical support, and that can be a bridge, to transplant. But 50% survival is out of place. So for this option, I'll go to option A. So the survival, the prognosis is poor, and they need emergent transplant. Any contributions?
Sorry, sir. I don't know why is D. I didn't get the reason why D is not the answer.
Immunosuppressive and have not been shown to improve survival in viral myocarditis.
Sorry, I said D.
Oh, the antibodies. Okay.
Yes.
So with the viral myocarditis, you know, it's not like a cross reactivity between the virus and the myocardium. It's mainly a direct effect of the virus on the myocardium, producing the inflammation and all. So measuring the antibody is not going to be of any prognostic value.
Okay, sir. Thank you, sir.
Yeah.
So what's the answer here?
Okay.
What's the answer?
A. Okay, moving on. Question 102. You are evaluating a 42-year-old woman with a history of Hashimoto thyroiditis many years ago, who was treated successfully with radioiodine. She presents to the emergency department after passing out at home and reports several days of worsening lethargy and chest discomfort. She is short of breath with a resting heart rate of 110 per minute and a blood pressure of 77/62. Her extremities are cold and she seems sleepy. Her whole blood lactate is elevated. So it's already having hypoperfusion. And urine output for the first 2 hours of her stay is minimal. On cardiac monitor, she repeatedly has salvos of non-sustained ventricular tachycardia. Echocardiogram revealed a left ventricular ejection fraction of 15%. And emergent endomyocardial biopsy shows diffuse granulomatous lesions surrounded by extensive inflammatory infiltrate. Which of the following statement is true regarding a diagnosis? Okay, so this one is clinical presentation similar to the first question. So this patient is basically in cardiogenic shock. Okay, and EF very low, is already having episodes of VT, non-sustained VT, and they're able to do urgent biopsy, and it's showing a granulomatous lesion. Okay, so when you see granulomatous lesion, the first thing that comes to the head is sarcoid. But however, in this case, because the granulomatous lesions are surrounded by extensive inflammatory infiltrates, then, you know, sarcoid is not, so you're dealing with a more acute condition. Sarcoid is a chronic inflammatory state. So you see granulomatous lesion, but you do not see acute inflammation around, inflammatory infiltrates around the lesions. So with this one, you know, this sort of picture points more towards a giant cell myocarditis. Okay, and this one also has very poor prognosis. In fact, even almost similar prognosis like a fulminant myocarditis. Okay, so the option says, so the question is, which of the following statement is true regarding her diagnosis? A, most patients with this etiology of cardiomyopathy recover with supportive care. That is false. Steroids are highly effective in treating this form of cardiomyopathy. Also not true. The cause of this cardiomyopathy is there, often with rapid deterioration requiring urgent transplant. So similar picture like before. So this is actually the two options. D, while seen occasionally, ventricular tachyarrhythmia are rare in this disease. That is not 2. And then none of the above is 2. That is also not 2. So C is the appropriate answer for this one. Any contributions? All right. Question 103. All of the following are associated with an elevated risk for development of cardiomyopathy during anthracycline chemotherapy. Okay, so this question is for you, Florence. Chemotherapy-induced cardiomyopathy. So A is concomitant chest radiation, which is 2, that can worsen anthracycline-induced cardiomyopathy. High total anthracycline dose, of course. Pre-existing cardiac disease also increase the risk. Trastuzumab administration. So this is also another chemotherapeutic that has toxic effects on the heart. So it will worsen. And then E is all of the above associated with elevated risk, and that is 2. So the answer for this one is E. Okay, so all of these ones listed here can increase the risk of development of cardiomyopathy when a patient is on anthracycline. Any comments? Florence, you must make a comment.
How you see the answer?
Sorry?
How you see the answer?
All of them. Oh, is it all of
Maybe
the
except
above
I'm not
associated
understanding well.
with okay, the way they put the question, okay, say all of the following are associated with elevated risk of development of cardiomyopathy.
Okay, okay,
Except,
okay.
So, but none of,
So,
all of them are associated. So, all of the above are associated with developing the risk. So there is no, among those that listed, there is no exception.
So if there's
Okay,
no
so
exception, sorry, sir. If there's no exception, that means even E. It shouldn't be.
that was my confusion now.
That's what I think.
Sorry? Dr. Onyebuze.
No, I said that was the same confusion.
Okay. So I don't know, it seems a bit confusing when they're using except. But they've used except, but all these are 2. And then the answer E is the 2 statements. So although if you look at it technically, they're saying all of the following elevate the risk except. So all of these options, they elevate the risk. Okay, and this is a statement. So it does not increase the risk if you're looking at it from that perspective.
So, Dr. Conte, are you saying E is the except? E?
Yes, because concomitant chest radiation will increase the risk. Total anthracycline dose, of course, high dose will increase the risk. If they have pre-existing cardiac condition, will increase the risk. Trastuzumab is another chemotherapy that also causes cardiomyopathy. So all of the above are associated with the, so this is a statement, okay, even though it's corroborating, but as a statement as it is, it does not increase the risk. It is the only thing in there that does not increase the risk. So that's why it's the answer.
Okay.
Like they are now bringing profs English.
I was thinking the cat was that due to anthracycline. I think it's a bit cold. I don't know. The end of the statement.
I think I'm also thinking that last statement that due to anthracyclines, because I think Ford was actually looking for things that will increase the development of cardiomyopathy with someone that is already on anthracycline.
Yeah.
Yes.
If you are now saying the risk of cardiomyopathy is increased due to anthracycline, it becomes negative.
No.
Because you're looking for what will be what will add to
additional
anthracycline, additional risk
factor
with the anthracycline.
All of the following are associated with an elevated risk of developing cardiomyopathy due to anthracycline chemotherapy. So are you saying this B should not be there?
No, my point is that my point is that we're saying, looking at option E, we're saying all of the above are associated with elevated risk of cardiomyopathy due to anthracycline. So are we saying that all of the above are due to, as a result of anthracycline?
Yes, because these things, when they are a patient already, let's say for option A, a patient is on anthracycline and then has a concomitant chest radiation, definitely the person will develop, it will worsen the cardiomyopathy.
No, okay, I actually go.
That means E is a tautology because you're already saying anthracycline is already basic, and you're adding I don't even know how to explain this. So I think this E is.
It's just Florence, please, you have to talk.
Okay,
You are the authority.
I think the problem is with the English. You know, they're asking for excepts. So now they're now saying all of the following, all of the above are associated with elevated risks of cardiomyopathy due to anthracycline. They are looking for excepts. So this option is actually wrong. I don't know if you get what I'm trying to say. So this option is actually wrong because they're looking for an except. So that's why that is wrong. I don't know if you understand what I'm trying to say. I don't. Do you get me? They're looking for an except. What is wrong? Oh.
E is
Thank
wrong.
you, ma.
They are saying E is right.
So okay. So
but the E, ma. Sorry, ma. It's not that we want to drag this thing, but just want to get it clear. The E as an option. Let's say it was for the option E, looking at the whole statement, is it a true or a false option?
Okay, looking at it.
So maybe I should just say something, Dr. Florence,
okay.
So that we can move on. Sorry to cut you short because I want us to finish this thing as early as possible. You know, the question is all of the, just like Dr. Conte is explaining, all of the following are associated with an elevated risk for development of cardiomyopathy during anthracycline chemotherapy, except, so we agree, concomitant chest radiation during anthracycline chemotherapy will increase the risk. That one is true. You understand? So it's not except it's not the answer we are looking for. High total anthracycline dose. That one is a true statement. You understand? Pre-existing cardiac disease will increase the risk. Trastuzumab, either in combination or as a single dose, will increase the risk. Do you get that? So this last option now is saying leave the last due to anthracycline. Just read all of the above are associated with elevated risk of cardiomyopathy. It will be a true statement. But they now said due to anthracycline. So, like high total anthracycline dose, that one might be due to anthracycline. Concomitant chest radiation on its own is not due to anthracycline. Do you understand? Preceding cardiac disease on its own is not due to anthracycline. Do you get the point? It might be only B that is due to anthracycline. I'm not sure you get the point. So it's the due to anthracycline that is in front that makes this statement false.
Yes, thank you, too.
Dr. Conte, Dr. Allison, thank you. Dr. Conte, what was the answer on the book? And what was their explanation?
It was actually E that was picked.
Okay, what was it? Can you read the explanation?
It's a bit long, but let me just read the last statement. Except, do you want me to read everything, sir?
How long it is? Just read it. You can learn a lot from it. Just read it. That will be clear.
Okay, it says anthracyclines cause characteristic histologic changes of vacuolar degeneration and myofibrillar loss in the heart, generation of reactive oxygen species involving heme compounds is currently the favored explanation for myocyte injury and fibrosis. Disruption of the large titin protein may contribute to loss of sarcomere organization. Risk for cardiotoxicity increases with higher doses, pre-existing cardiac disease, and concomitant chest irradiation. There are three different presentations of anthracycline-induced cardiomyopathy. One, heart failure can develop acutely during administration of a single dose, but may clinically resolve in a few weeks. Two, early onset doxorubicin cardiotoxicity develops in about 3% of patients during or shortly after a chronic course, relating closely to total dose. It may be rapidly progressive, but may also resolve to good but not normal ventricular function. Three, the chronic presentation differs according to whether therapy was given before or after puberty. Patients who received doxorubicin while still growing may have impaired development of the heart, which leads to clinical heart failure by the time the patient reaches the early 20s. Late after adult exposure, patients may develop the gradual onset of symptoms or an acute onset precipitated by a reversible second insult, such as influenza or atrial fibrillation. Trastuzumab, that's a Herceptin, is a monoclonal antibody that interferes with cell surface receptors, crucial for some tumor growth and for cardiac adaptation. The incidence of cardiotoxicity is lower than for anthracyclines when given alone, but enhanced by co-administration with them. Thank you.
Oh, that's all?
Yes, sir.
So it didn't quite even emphasize why the E option is true. But then let's go with what Alice did. It might just be due to the interest. Okay. Let's just go so that we can save time. We have over 60-something questions to answer.
Question 104. Mr. Kia is a 32-year-old bass guitarist with no past medical history. He presents with chest pain after suffering coryza, cough, fever, and muscle aches for the past week. He described his pain as constant and radiating to his left shoulder. It is exacerbated by lying flat and during deep breaths. Examination revealed a rasping extracardiac sound present in three components per heartbeat. His ECG is pictured in figure 104 below. Troponin levels are undetectable on presentation and 6 hours later. Blood pressure, heart rate, and oxygen saturation are normal. What is the most appropriate next step? Okay, so the ECG is showing the typical findings of pericarditis. So it's a saddle-shaped ST elevation, widespread, and then with the reciprocal change in AVR. Okay, where you now have the ST elevation. Okay, and this one is also showing the spodic sign. Okay, downsloping of the TP segment. So this one is pericarditis. So what would be the most appropriate next step? A, aspirin 81 milligram daily, metoprolol 25 twice daily, and atorvastatin. That won't be correct. The dose of, you can use aspirin, but that dose is low. And then the atorvastatin you don't need at all. B, aspirin 1 gram 8 hourly with omeprazole 20 milligram daily. That will be correct. So the omeprazole to prevent the GI side effects of the high dose aspirin. Heparin, aspirin, clopidogrel, and immediate coronary angiogram. This is not MI, so that is not correct. D, prednisone 40 milligram daily for 2 weeks, followed by a taper over the ensuing 2 months. So steroid is not the first line. In fact, it's been shown to be associated with recurrence when you use steroid. So although there are certain special situations when you want to use steroid, but in this case, steroid is not the most appropriate. Transthoracic echocardiogram. You can do echo, but at this point, this patient, you've gotten your diagnosis from the ECG, you can treat and then do the echo. If they were having signs to suggest significant pericardial effusion, then you want to do echo to confirm it, but it's just having the pericardial pain and with typical ECG findings. So I'll go with the answer B as the most appropriate next step. Any contribution? All right. 105. You are caring for a 45-year-old man in the cardiac intensive care unit. He presents with chest pain and initially was thought to have acute coronary syndrome, prompting initiation of antiplatelet agent and IV heparin. After complete assessment and the return of negative serial cardiac enzymes, it became clear that he instead had acute pericarditis. Shortly after admission to the cardiac intensive care unit, he became hypotensive with elevated neck veins. His lungs are clear to auscultation. His extremities are cold, and you note that his brachial pulse is only palpable during expiration. Okay, interesting. So that is actually pulsus paradoxus. What is the most likely diagnosis? This one, just go and look for the answer, which is tamponade. So yes, cardiac tamponade B. All the other things won't fit. Aortic dissection, that will not be the presentation. Left main coronary artery occlusion, we've already ruled out coronary artery disease. Ruptured chordae tendineae, this one it will not give you the pulsus paradoxus. And then, the pulsus paradoxus will not be there. And with the background history of pericarditis, so this is mostly likely tamponade. Ventricular septal defect, certainly not, it does not fit the picture. So the option here will be B. All right, I think that concludes my part, Florence. All right.
Okay,
Good evening,
okay,
everyone.
Okay.
The answer is saying B and E respectively. Have you?
The answer is saying B and E respectively.
No, B. Okay, yes.
It's a joint question.
It's a joint question, yes.
Yeah.
Oh.
Okay,
So
just
you-
answer at once.
just
Since
do
we started it.
Sorry?
You can just finish it since it's already one.
Just finish it. It's a combined distance, so just finish it at once.
Florence, eh? Okay.
I know your sir. I know your.
All right. 106. So you call for
Sorry, Dr. Maduka.
The owner of the Dr. Conte can go ahead. You can go ahead. Who wants to
Okora for no verse, I beg.
No, I'm
Sorry.
vexed for that.
Florence, I'm listening to you. What do we do?
All right, good evening, everyone. I can continue. I'm taking from 106 to 110.
Okay, go ahead.
Good evening, everyone. Yeah, so like Dr. Conte said, the 106 is a follow-up of the preceding question. So it goes this way. You call for emergent echocardiography in the patient described in question 106. In this patient, which of the following is likely to be increased during inspiration compared to expiration? So, like he said, the preceding question is cardiac tamponade, and I think they're trying to talk about the principle of ventricular independence, in which when normally, if in a normal patient, once you inspire, okay, you increase the intrathoracic pressure, and then the blood tends to flow in more into the right side, while there is reduction of blood flow, okay, through the left side of the heart. And the reverse is the case when you expire. So when you expire, there is reduced blood flow through the right side, and then there is increased blood flow through the left side. And so in cardiac tamponade, this same thing happens, but it is usually exaggerated. And so that is what translates to Paul's paradoxes. So that said, they are asking which of the following is likely to be increased during inspiration compared to expiration. So whatever is going to be increased has to be at the right side. So if you look through all these questions, the options, A is left ventricular end diastolic diameter, which is wrong. Left ventricular stroke volume is wrong. The mitral inflow velocity, no, we expect that there will be reduced flow through the mitral valve. The systolic blood pressure, no, we don't expect that. And tricuspid inflow velocity. So that is the one that will be where we'll have increased flow through. So like I said, in cardiac tamponade, during inspiration, is increased intrathoracic pressure, and then there is more blood flow through the right side of the heart. Okay, so the correct option there is E. Any questions or contributions? Okay, we'll go to 107. All of the following ECG characteristics will aid in differentiating acute pericarditis from acute myocardial infarction, except. Okay, so we're looking for the wrong option here. So we'll now go through them. Absence of the development of Q waves. So if you recall the different stages of the changes, ECG changes in acute pericarditis, there is none that has anything to do with Q wave. And so the first stage, where you have ST segment elevation, usually described as a concave ST segment elevation with concomitant PR depression, okay, for the stage 1. So stage 2, the ST segment elevation gets to normal, and then as it goes to the normal, to the isoelectric point, actually. Then stage 3, you have T wave inversion, and then the fourth stage of the changes, where the ECG normalizes to the pre-event status. So you can now see that we can actually differentiate it with Q waves, because Q waves, you don't find it in acute pericarditis. So B, concave shaped to ST elevation. So that's a good way to differentiate. So acute pericarditis, you have concave shaped ST elevations, while in myocardial infarction is convex shaped. So PR depression, yes, you can use it for differentiating the two. ST segment elevation in V2. So that cannot be a differentiating factor, because you can find the ST segment elevation in V2 in myocardial infarction, okay? Especially when the septal aspect of the heart is involved. You can find it in V1, V2. You can also find ST segment elevation in V2 for pericarditis, so that's not a differentiating factor for the two. So that option is the correct option for this number. We'll look at E, T-wave inversion after return of ST segment to the baseline. So of course you cannot use this to differentiate between you can use this, to differentiate between pericarditis and the acute myocardial infarction. So for this 107, the correct option there is D. Okay. Any questions or contributions? All right, let's go to 108. A 35-year-old woman is admitted to the hospital with malaise, weight gain, increasing abdominal gait, and edema. The symptoms began about 3 months ago and gradually progressed. The patient reports an increase in waist size of approximately 15 cm. The swelling in her legs has gotten increasingly worse, such that she now feels her thighs are swollen as well. She has dyspnea on exertion and 2 pillow autopnea. She has a past history of Hodgkin's disease diagnosed at age 18. She was treated at that time with chemotherapy and mediastinal radiation. On physical examination, she has temporal wasting and appears chronically ill. Her current weight is 96 kg, an increase of 11 kg over the past 3 months. Her vital signs are normal. Her jugular venous pressure is 16 cm, that's elevated, and the neck veins do not collapse on inspiration. So that can pass for sign. Heart sounds are distant. There is a third heart sound heard shortly after aortic valve closure. The sound is short and abrupt and is heard best at the apex. The liver is enlarged and pulsatile. Ascites is present. There is pitting edema extending throughout the lower extremities and onto the abdominal wall. Echocardiogram shows pericardial thickening, dilation of the inferior vena cava and hepatic veins, an abrupt cessation of ventricular filling in early diastole. Ejection fraction is 65%. What is the best approach for treatment of this patient? So this is a long read, but in summary, is a young woman that had Hodgkin's disease at the age of 18, had chemotherapy and mediastinal radiation. So the answer to this question can be quickly gotten at the last sentence, actually, in addition to the other things that we have mentioned. So where it talked about echocardiogram shows pericardial thickening. So there's an issue with the pericardium of this patient, possibly constricted pericarditis, dilation of the inferior vena cava and hepatic vein, an abrupt cessation of ventricular filling in the early diastole. So this is a sign that in cardiac catheterization will give us the is that called the staircase sign or the Z sign? Okay, then ejection fraction is preserved. So we look through the option. Aggressive diuresis only. So the question is, what is the best approach for treatment in this patient? Aggressive diuresis only. Cardiac transplantation, no. Mitral valve replacement, that is wrong. Pericardial resection, and E, pericardiocentesis. So this patient essentially has constrictive pericarditis, and we know that it's important to differentiate it from restrictive, because it's said that it is one condition that you can actually intervene, and there will be some improvement. Okay, so what is needed is to peel off the thickening of the pericardium. So the pericardial resection is the answer to this question. Any contribution or question? All right.
Dr. Matthew, am I audible?
Yes. Yes.
Yeah. Just to add some few changes on the clinical scenario painted. So that auscultatory sound that was painted in the question is actually pericardial knock. We heard in patient with constrictive pericarditis. You best heard at the left ulnar edge, but can also be heard at the apex, as is written in this question. And also, the question also involved different risk factors for this constrictive pericarditis, the malignancy, the radiation, and some other risk factors could be autoimmune conditions and infections generally. TB should not be forgotten too as a possible cause for pericarditis. But these patients, the malignancy and the irradiation are the two risk factors. Thank you.
And thank you for the contribution. And this sign is actually square root sign. I think I said staircase sign. I don't know why that one came into my head. But it's square root sign. Okay. Thank you. All right. So a 45-year-old accountant with no prior past medical history has experienced occasional fevers, symmetric arthralgia, and fatigue for the past 3 months. 2 weeks ago, she experienced the sudden onset of left hand weakness, which resolved within 1 hour. Multiple blood cultures have been negative. Emergent evaluation at her local emergency department included a head CT that was unrevealing. Last week, she had a transthoracic echocardiogram that showed a solitary 2 cm mass in the left atrium arising from the interatrial septum in the vicinity of the fossa ovalis that appeared pedunculated on a fibrovascular stalk. We are seeing her back in the clinic today. What is the most appropriate next step? So this woman, first of all, this woman has atrial myxoma, which was beautifully described exactly the way it is in the textbook. So the usually found in the atrial septum is commoner in the left atrium. With the stalk, it has a stalk that we usually find exactly at the position for the fossa ovalis, and it's pedunculated. So this is the typical description. And you can find that initially this patient had constitutional symptoms of fever, okay, arthralgia and all that. So this patient has atrial myxoma. So what's the next step in treatment? A, cardiothoracic surgical removal of the mass, okay, which is the correct option here. But let's go through the other ones. Catheter-based biopsy of the mass. We recall that this is one condition in which doing a biopsy therefore is totally contraindicated because of the risk of embolization. So repeat blood cultures and inform the microbiology lab to plate on a special media. So that is obviously the wrong option. Okay, so can we scroll up? Thank you very much. The serologies for anti-nuclear antibodies, anti-DNA, so that is also wrong. Whole body PET scan is also wrong. So the answer here is to surgically remove the mass. We should also bear in mind that the atrial myxoma can also be involved in a complex, or the Canis complex, which involves what is called a skin manifestation known as the lentigens. Some text put it as the low-part skin, and they could have some endocrinopathies also. And these myxomas can also be seen in other parts of the body. Okay, so we should also have that in mind. Any contributions, please? All right, so number 110. Which of the following malignancies carries the highest relative risk of metastasis to the heart? So like Dr. Conte will always say, we just go ahead and pick out the answer. We know that the malignancy that metastasizes most, has the highest risk of metastasis to the heart, is malignant melanoma. So that is the correct option. So the other options here, glioblastoma, which is wrong, hepatocellular carcinoma, which is wrong, pancreatic adenocarcinoma, which is wrong, small cell lung cancer, which is also wrong. But the correct option here is malignant melanoma. Okay. Any questions? Okay. Thank you very much. I think this should be the end of my part.
Hello, Korafo.
Yes, sir.
Yeah, what about what's the position of the met from breast cancer? Breast cancer. And I think the other one is it lung cancer also?
Lung cancer and breast cancer. So the commonest, the secondary tumor that metastasizes most to the heart is the malignant melanoma. The position of 3 and 4, if I'm not mistaken, is occupied by breast cancer and lymphoma. But I'm not sure which one takes the second and the third. I'm not very sure which one takes the second and the third. So it's malignant melanoma first, then the next is breast cancer or lymphoma. If my memory serves me right, I would rather choose lymphoma before breast cancer. So, but I will look it up and I'll post it in the page.
Thank you.
Yes, sir.
Okay, thank you so much, Dr. Maduka, for taking your part. We appreciate your efforts. To the next person to take her presentation is Dr. Etiebo. Dr. Etiebo. Dr. Etiebo Josephine.
Yes, I'm here.
Okay.
Good evening, all.
Good evening.
Good evening. Okay. So I'll be taking questions 121 to 125. Can we just take it to 121? 121. Question 121. Can you bring it down a little? So It's a follow-up from question 120. So it reads, as Mr. Jackson from question 120 continues on his exercise stress test, he begins to complain of a pressure-like chest pain. You suspect that he's experiencing angina due to a partially occluded coronary artery. Oh. Okay, Prof wants me to start from.
Yeah, exactly. I think that makes sense. Have we taken 120 before? Florence, have we done 120?
Okay, 120. Yes, wait, let me check. Yes, it has been attempted.
Okay, well, I think you can just review it so that you have a flow to the question.
Okay. So Mr. Jackson is undergoing an exercise stress test. You know that as he progresses through his stress test, his myocardium will require more oxygen. How does the normal non-diseased heart respond to meet its higher oxygen demand? A, increase myocardial oxygen extraction during near constant coronary blood flow. Increase oxygen extraction from the ventricular chambers. C, relative expansion of the diastolic time period allowing increased coronary flow. D, vasodilatation of epicardial coronary arteries leading to decreased resistance and increased coronary blood flow. E, vasodilatation of intramyocardial coronary vessels leading to increased coronary blood flow. During exercise, the normal non-disease heart responds to meet its higher oxygen demand by causing there is a vasodilatation in the intramyocardial coronary blood flow to allow for increased coronary blood flow. So that's what is the usual response to exercise in a normal heart. So the others did not fall into the normal response. So 121. So as Mr. Jackson continues on his exercise stress test, he begins to complain of a pressure-like chest pain. He suspects that he's experiencing angina due to a partially occluded coronary artery. If you were able to immediately analyze the biochemical changes during his ischemic myocardium, you would note all of the following except. So during ischemia, a wide variety of abnormalities occur in cell metabolism, function, and structure. So with when there is a severe deprivation of oxygen in the myocytes, so what happens is that fatty acids and glucose is usually used to get energy and usually converted to carbon dioxide and water. They cannot be oxidized because there is oxygen deprivation. So the body now shifts to using anaerobic method of metabolism. And so the outcome is that glucose and fatty acids, they are converted to lactate. The intracellular pH is reduced, and high energy phosphates such as adenosine triphosphates, ATP, and creatine phosphates are reduced. The cell membrane functions are impaired, and this leads to leakage of potassium, uptake of sodium by the myocytes, and increase in cytosolic calcium. So having this in mind, can approach the questions to look for the except. So it says an increase in cytosolic calcium, which is true, an increase in intracellular pH, That one is false. There's a reduction in intracellular pH. And there's a shift from anaerobic to anaerobic metabolism, true. Depletion of myocardial stores of high energy phosphates, true. Leakage of potassium from myocyte, true. So the except here is increase in intracellular pH, supposed to be decrease in intracellular pH. So B is the answer here. 122, please. Which of the following sites is an unusual anatomic location for vaginal pain? So the usual or typical vaginal pain will radiate to the back, will radiate to the interscapular region or to the roots of the neck, and also the teeth. So A, B, C, D, they are correct. They are correct for typical radiation. Usual anatomic location for vaginal pain radiation is A, B, C, D. But for the E, the trapezius muscle, that's like the atypical or unusual anatomic location for radiation of vaginal pain. Option 123. Question 123. Miss Wilson is a 66-year-old postmenopausal U.S. postal employee. While working on mail routes over the past 9 months, she has routinely experienced chest pressure and dyspnea while climbing a certain steep hill. The pressure resolves when she rests for about 3 minutes. She has not missed any work due to these symptoms. You suspect she's experiencing angina. What term and Canadian Cardiovascular Society functional class of angina is appropriate to describe her symptoms? The Canadian Cardiovascular Society classified angina symptoms into functional class 1 to 4. For class 1, for functional class 1, they have or rather, they do not, ordinary activities, ordinary physical activities, such as climbing stairs, walking distances, does not cause angina. So as for class 1, then for class 2, there's a slight limitation of ordinary activity, such as walking or climbing staircase. Then for class 3, there's marked limitation of ordinary physical activity. For class 4, there's inability to perform any physical activity without discomfort. So angina syndrome may be present at rest. That's class 4. For Miss Wilson, she experienced chest discomfort for 9 months or so while climbing a certain steep hill. So that can be taken for flights of stairs, for example, then which usually resolves about 3 minutes and doesn't disturb her work. She's able to do her work. She did not miss any work day. So we can say she's in functional class 2, stable angina, Canadian cardiovascular classification class 2. So can give her that class 2. Then for the E option, E says unstable angina. Stable angina is also stable angina with severe and prolonged symptoms. We cannot actually say that this woman is having unstable angina. So class 2 correctly describes her symptoms. So option B is the correct option for her. (124) A 50-year-old accountant with a history of cigarette use completed an exercise treadmill ECG stress test. During his test, he developed upsloping ST depressions in leads 2, 3, and AVF. His peak heart rate achieved was 130 beats per minute. His blood pressure increased from 120/80 to 155/95 millimeters of mercury. What is the appropriate interpretation of his stress test? So, what we are looking at here is the fact that, first of all, we want to look at what is supposed to, the heart rate is supposed to achieve during exercise. So to calculate the maximal predicted heart rate, we use 220 minus H. And we expect that it's able to achieve 85% of its maximum predicted heart rate. So if we look at 220 minus his age, 50 years, we are going to get 170. Then if we will get 170, then 85% of 170 will give us like approximately 145. So this 50-year-old accountant is not able to do up to 145. He was able to achieve his peak heart rate during the exercise was 130 before he developed symptoms, before he developed upsloping ST segment depression in the leads. So that is one. Then two is we expect that during exercise, blood pressure the blood pressure goes up, and his blood pressure actually rose to 155/95 from his 120/80. So that one is a normal response. Then for the ECG findings of upsloping ST segment depression in the inferior leads, and that is actually not considered characteristic of ischemia. Ischemia do not constitute a positive test. What constitutes a positive result is downsloping depression of the ST segment greater than 0.1 millivolts below baseline using the PRO segment, and when it also lasts longer than 0.08 seconds. So for these patients, we will say that so option A, negative stress test, inappropriate hypertensive response to exercise. That is incorrect. The negative stress test, non-specific ST changes. That's also not correct. Non-diagnostic stress test, normal blood pressure response. That's the correct option for this that interprets his stress test report. Then positive stress tests, inappropriate hypertensive response to exercise, that's not correct. Positive stress test, normal blood pressure response. So option C correctly explains its results of stress test. I don't know if I'm able to explain the patient's condition and results.
That's fine, you can proceed.
Thank you. A 70-year-old woman presents to the emergency department with 3 hours of acute shortness of breath and crushing substernal chest pressure. Her ECG shows 1 millimeter ST depression in leads 2, 3, and AVF without any ST elevation. Initial serum troponin level is mildly elevated. You suspect that she's having a non-ST segment elevation MI, a myocardial infarction, NSTEMI. All of the following are causes of NSTEMI except. So causes of NSTEMI includes a partially occluding thrombus forming on a disrupted atherothrombotic coronary plaque or an eroded coronary artery endothelium. It also includes dynamic obstruction due to coronary spasm, such as in presmental variant angina, and also severe mechanical obstruction due to progressive coronary atherosclerosis. Can also be seen in increased myocardial oxygen demand produced by systemic conditions such as fever, tachycardia, and thyrotoxicosis in the presence of fixed epicardial coronary obstruction. So, but for coronary spasm, which is the option A there, okay, coronary spasm is true. It's not the correct option. It's not the except. B, increased myocardial oxygen demand produced by, so that's not the except. They are both, A and B are both causes of NSTEMI. Then C, microvascular endothelial dysfunction. And that can actually cause chest pain, can cause angina, but has not been shown to cause myocardial infarction. Then D, partially occluding thrombus forming on disrupted atherothrombotic coronary plaque, correct, is a cause of NSTEMI, progressive coronary arteriosclerosis leading to severe mechanical obstruction is also a cause of NSTEMI. So the C option is not in keeping with causes of NSTEMI. My questions have ended.
Okay, thank you so much, Dr. Josephine Etiebo, for taking your part. We appreciate your efforts. Okay, so the next person is Dr. Mokorede. Dr. Mokorede, you can please have the floor. Thank you.
Hello, good evening.
Yeah,
good
good
evening,
evening.
Teachers and facilitators. Good evening, colleagues. So to take 126 to 130. Mr. Brian is a 57-year-old hockey team coach with a prior history of hypertension, hyperlipidemia, and tobacco use, chest discomfort during a practice. He notices that he first began experiencing chest discomfort 3 weeks prior with vigorous exertion during practice. However, over the last week, it has taken less exertion to initiate the discomfort. So that's this thing is actually getting worse. Tonight, it occurred while he was just sitting on the bench. He describes his discomfort as a pressure radiating to his jaw. It typically lasts about 10 minutes. His ECG shows T-wave inversions in leads 1, 2, AVL, V5, and V6. Those are T-wave inversions. Since his last cardiogram 2 years ago at a routine physical examination. Which of the following clinical Brian? So option A, non-ST segment salivation myocardial infarction. Option B, ST segment salivation myocardial infarction. C is stable angina. D is unstable angina. E, more information is required before making a diagnosis. So for this patient has chest pain, which is almost typical, is worsening with decreasing exertion, and is even getting to, is worse even at rest. Shows that there's some form of obstructive coronary obstruction going on, which we are also seeing from the baseline ECG that he did. So if we say stable angina, we expect stable angina to actually get better with rest. So from the options, option C is ruled out. So if we're talking about non-ST segment myocardial infarction, for us to make an assessment of myocardial infarction, we need both ECG and biochemical parameters to confirm, rule in or rule out this diagnosis. So for this patient, we have ECG, we have clinical, but we don't have biochemical confirmation. So option A is not going to be the correct answer because we don't have biochemical markers to ascertain whether it's option A or is just option D. So we know that ST elevation myocardial infarction is already out of it, as what we have are just T-wave inversions on the lateral ECG leads that this patient has. So for us to make an assessment as to whether this patient has just straightforward unstable angina, where we expect the troponins or the serum biomarkers to be relatively normal, or we'll make an assessment of non-ST segment elevation where we expect the troponins to be elevated, it's important we go to option E, where more information will actually be required. So it's advisable that this kind of patient should do serum troponin so that we can clarify whether the patient has unstable angina or non-ST segment elevation myocardial infarction. So the answer is option E. More information is required to make a diagnosis of this patient. Okay, next question, 127. Mr. Rivera, a 42-year-old man with anuric end-stage renal disease due to DM, due to recent car troubles, he missed his most recent dialysis appointment and presents to the emergency department with shortness of breath. His heart rate is 105 beats per minute. Blood pressure is 185/100. And then he has fine rales at the bilateral lower lung zones, and his jugular venous pressure is also elevated. So ECG shows sinus tachycardia without ST segment deviation, and the initial troponin assay returns as 0.14 nanogram per dl, where the normal is supposed to be less than 0.06 nanograms per dl. What are the most appropriate therapeutic and diagnostic steps in this patient? So before we go to the options, I would like us to just look at this patient. Is a known CKD patient who missed his dialysis. So we expect that it's most likely going to be congested and would require urgent hemodialysis. And the uremic state can lead to the increased heart rate. Then probably poor drug compliance or running out of medications can also account for the elevated blood pressure. So because of the congestion that he has due to missing the dialysis, you will have rales in the lower lung zones, the JVP will be elevated due to congestion. And it's important to note that chronic kidney disease is one of the causes of increase in troponin. So the fact that the troponin of this particular patient is elevated does not mean that the ST segment elevation is going towards the area of coronary artery disease. Also, the fact that they didn't even mention whether they are contiguous. There is even no ST elevation in this patient. So the fact that troponin is high, that doesn't rule in coronary artery disease in this patient. So the options. So the option A will be administer 80 milligram of IV furosemide, follow serial troponin, high values, and ECG. Option B is administer 80 milligram of aspirin and refer for pharmacologic nuclear stress testing. Okay, maybe I should just debunk each option as I'm moving on. So 80 milligram of furosemide, yes, that's actually a fine move for this particular patient because you want to decongest the patient. But why are we doing serial troponin high ECGs when we know that chronic kidney disease that this patient has would actually be the most likely cause of the elevated troponin? So there is no need wasting patients' time by repeating the serial troponin. So that second part makes the option wrong. So administer 80 milligram of aspirin. There is no indication for aspirin use in this patient. Initiate dual platelet antiplatelet therapy. There's also no indication in this patient. There is no chest pain. There is no ST segment elevation, and even though the troponins are elevated, so there is no indication for antiplatelet therapy in this patient. So in option C and option D will be wrong. So initiate urgent hemodialysis with ultrafiltration for fluid removal. Then you can follow serial troponin I values and then ECG. It's not the main thing for this patient is actually to do the hemodialysis just to rule out coronary artery disease, but we know that it most likely will not be significantly, there may be no significant changes, but we want to look at the troponin in view or in line with the ECG and not just the troponin in isolation in this particular patient. So any other contribution?
Okay, and just to add on, because this patient is anuric, not making urine at all, so that one is an indication for hemodialysis.
Yeah.
Yeah, thank you.
Okay. Thank you. So question 128. A 67-year-old fry chef at local waffle emporium presents to the emergency department with sudden onset of crushing substernal chest pain. He has a history of hypertension, hyperlipidemia, ED, for which he takes daily amlodipine, simvastatin, and tadalafil. On your evaluation, blood pressure is 145/85, heart rate 90. The lungs are clear, JVP is not elevated, no murmurs or gallop or cardiac auscultation. He complains of chest discomfort, rating it as high as 8/10. So initial troponin I results is elevated at 0.52 nanograms per ml per DL, and then the ECG is revealing 1 mmST segment depression in 2-3 AVF, V5, and V6. So that's non-STEMI. All of the following pharmacological therapies are reasonable to administer, except, so before I read the options, what I want us to note are the medications this patient is already on amlodipine, simvastatin, and tadalafil. So, and then the patient also has clinical, biochemical, and ECG features of non-ST segment elevation. So for this patient, we want to give aspirin orally. We want to give clopidogrel. We can also give unfractionated heparin, metoprolol also to slow down the heart rates. We want it to be at least less than 70, unlike the heart rate of 90. Then the option E is nitroglycerin. In the typical setting of non-STEMI, yes, nitroglycerin will be a good option. But this patient is already on tadalafil. And we've discussed, and we know that we discussed previously that you don't combine tadalafil and the nitrates because of the exaggerated response to significantly drop blood pressure. So you don't want it to crash the blood pressure. So a combination of, so we must always note that when we are looking at medications of patients, we don't combine sildenafil, tadalafil with nitrates generally. So option E will not be administered to this patient because the patient is already on tadalafil for the erectile dysfunction. So that's the answer to number 128. Nitroglycerin sublingually will not be given. So number 129, Mr. Gilotra is a 57-year-old oil rig worker with history of hypertension, tobacco use, and DM. He presents chest pain, radiating to the jaw, with a step profuse sweating and shortness of breath. The blood pressure is 115/90. Heart rate is 95 beats per minute. What diagnostic test will provide the most rapid method? So it's important to note the management for Mr. Gilotra. So 57-year-old with background, significant risk factors, hypertension, tobacco, DM, crushing. The chest pain is crushing, radiating the jaw. And then there's sweating. So we are suspecting that this patient has an ongoing acute coronary syndrome. So what we want to do that would like most rapidly or allow us to actually act fast. So the easiest thing that we can do for these patients is to off the ECG, just baseline. Then when we see the ECG, we don't want to go ahead with echo, go ahead with the cross, painting a typical picture that we see in our normal day-to-day clinical setting. And it's ECG that would go ahead and so the answer is A. So number 130, you are evaluating a patient with chest pain in the ED. ECG shows no Q waves or ST segment changes. You wish to know whether the patient is suffering a myocardial infarction. Which of the following biomarkers is the preferred biochemical marker for myocardial infarction? So we need to look at the question again. So the most is the preferred, which one do we want? So we know that creatinine kinase can be used as a marker for myocardial infarction, but it's not the first line. It's not what we want to do routinely. CKMB band. It's not also the most preferred. ESR is not even in the picture. Lactate dehydrogenase can also be used in some settings, but it's not the most preferred. But we all know that troponin high for first. So troponin I is the most preferred biomarker for myocardial infarction. So the answer is option E. It's a very straightforward question. Thank you very much. That's the end of my that's the end of questions I was allotted to me. Thank you.
Maybe just an add-on. I think from all the biomarkers, troponin I is most specific. The other ones you can see them in other conditions, or the skeletal problems and all. So, but the troponin I is very specific to the myocardium. So I think maybe that's why it's most preferred from every other thing here.
Yes.
Okay. All right. Thank you so much, Dr. Mokorede, for turning up. Thank you. We appreciate the effort. All right. So the next person to present is Dr. Ofosu. Dr. Ofosu on the call.
Yes. Hello. Good evening.
Yeah. Good evening. Thank you.
Good evening, everyone. Okay. So I'll be taking 1312135. So question 131. You are performing a diagnostic coronary angiogram on Mr. Hayes. On the initial angiographic picture, his arteries are clear of any obstructive disease. However, during the selective angiogram of the left anterior descending artery, you notice that a thrombus has formed on the tip of the catheter. During dye injection, the thrombus embolizes down the left anterior descending coronary artery, causing complete obstruction to flow. Fortunately, you are able to remove the thrombus with suction thrombectomy almost immediately. If you had not been able to remove the thrombus, when would you first have expected detectable CKMB isoform in a standard serum assay? So option A, 5 to 10 minutes, B, 1 to 2 hours, C, 4 to 8 hours, D, 12 to 24 hours, and E, 24 to 48 hours. So as we know, cardiac markers are used for diagnosis and risk stratification of patients with chest pain and also suspected acute coronary syndrome, and for the management and prognosis in patients with acute heart failure, pulmonary embolism, and other disease states. So the cardiac markers can be classified into those that signify myocardial necrosis, and these are the CKMB and the myoglobin and the cardiac troponins, troponin I and then T. And also those that indicate myocardial ischemia. This is ischemia modified albumin, and those that suggest myocardial stress, and this includes the natriuretic peptides. The level of cardiac enzymes change over time after myocardial infarction, and these changes can help diagnose and monitor the patient. So with CKMB, the level increases within 4 to 8 hours after symptoms begin, and it peaks around 24 hours. However, it returns to normal within 48 to 72 hours. And CKMB levels can be useful for detecting a reinfarction within 4 to 10 days of the initial event. Then troponin I, its onset is within 3 to 12 hours. Level peaks within 24 hours and begin to return to normal within 5 to 10 days. And troponin I is more specific to the heart than other cardiac enzymes, making it more reliable biomarker for diagnosing acute myocardial infarction in patients with chronic renal failure. And then troponin T, its onset is within 3 to 12 hours. Levels peak within 12 to 48 hours, and it returns to normal within 5 to 14 days. So it lasts a bit longer than the troponin I. Troponin T is not specific to the heart and can increase without myocardial damage, especially in patients with chronic renal failure. Okay, so back to the question. When
Hello, Dr. Fosu. I don't know, I can't hear you. I don't know if I'm the only one.
eight hours.
Dr. Fosu?
Okay. Yes.
Okay, I wasn't hearing you initially.
Okay. So I think that the correct answer will be C, 4 to 8 hours for CKMB. Okay, so we can go to the next question. So question 132. The greatest delay between symptom onsets and definitive therapy for patients with ST segment elevation myocardial infarction usually occur in what time interval? So A, between onset of pain and patient's decision to call for help. B, between patient's call and emergency medical team arrival. C, between emergency medical team arrival and arrival at the hospital. And D, between arrival at the hospital and decision to initiation reperfusion therapy. And then E, between decision to initiate reperfusion therapy and the actual initiation of this therapy. Okay, so it's been well documented that most out-of-hospital deaths from ST elevation MI are due to sudden development of ventricular fibrillation. And a vast majority of the deaths due to ventricular fibrillation occur within the first 24 hours of the onset of symptoms. And of these, over half of the deaths occur within the first hour. Therefore, the major elements of pre-hospital care of patients with suspected ST elevation MI include one, the recognition of the symptom by the patients and prompt seeking of medical attention. Two, deployment of an emergency medical team that is capable of performing resuscitative maneuvers, including defibrillation. And then thirdly, expeditious transportation of the patients to a hospital facility that is continuously staffed with doctors and nurses skilled in managing arrhythmias and so providing advanced cardiac life support. And lastly, the expeditious implementation of reperfusion therapy. And the greatest delay usually occurs not during the transportation to the hospital, but rather between the onset of the pain and the patient's decision to call for help. And this delay can best be reduced by educating the public concerning the significance of chest discomfort and the importance of seeking early medical attention. So for 132, the correct answer will be A. That is between the onset of pain and patient decision to call for help. Okay, so any contribution on this or question? If not, then we can move on to the next question. Okay, so question 133. All of the following medications used in acute management of ST segment elevation myocardial infarction are appropriately matched to their mechanism of effects, except. Okay, so we are looking for one that is wrongly matched with its mechanism of action. So A, aspirin, reduction in thromboxane A2. B, abscesimab, inhibition of glycoprotein 2B and 3A receptor. C, beta-adrenergic antagonist, reduce myocardial oxygen consumption. D, clopidogrel, inhibition of platelets adenosine diphosphate receptor. And then E, nitroglycerin, reduction of cardiac afterload. Okay, so for A, aspirin, aspirin is an irreversible cyclooxygenase inhibitor, and thus it inhibits the production of thromboxane A2. So the A will be correct. And then B, abscesimab. Abscesimab, which is a Fab fragment of a chimeric human murine monoclonal antibody 7E3. And abscesimab binds to the glycoprotein 2B and then 3A receptor of human platelets and inhibits platelet aggregation by preventing the binding of fibrinogen, von Willebrand factor, and other adhesive molecules. So the option B is also the correct mechanism. And then the next one being the beta blocker. Beta blockers reduce myocardial oxygen demand by reducing cardiac chronotropy and inotropy. They should be used with caution in patients with myocardial infarction and any sign of delayed conduction, such as AV blocks. And also should be used with caution in patients with heart failure and those who are at risk of cardiogenic shock. So C is also correct, that it reduces myocardial oxygen demand. And then D, clopidogrel, it inhibits the P2Y12 adenosine diphosphate platelet receptor to inhibit platelet aggregation. So that's one is also a true combination. And then E, nitroglycerin. Nitroglycerin is effective for angina effects. These angina effects in the setting of ST elevation MR. And it does this through decreasing preload and also through direct nitric oxide induced coronary vasodilatation. Nitric oxide is converted by mitochondrial aldehyde. Aldehyde dehydrogenase in smooth muscle cells to nitric oxide, which is a potent vasodilator. And nitric oxide activates enzyme granulase cyclase, which converts guanosine triphosphate to cyclic GMP in vascular, smooth muscles, and other tissue. Cyclic GMP is an endogenous vasodilator of vascular smooth muscles, and it causes protein kinase dependence phosphorylation and activates a downstream cascade that promotes relaxation and increased blood flow in veins, arteries, and also cardiac tissues. And nitroglycerin has minimal effects on systemic afterload. Okay, so for this question, E will be the correct answer because it says nitroglycerin reduces cardiac afterload, but rather it reduces more of cardiac preload and has very little effect on cardiac afterload. So that will be the right answer, E. Okay. Any contribution, please, or questions? Okay, so we'll move to the next question. So 134. A 61-year-old man presented to the emergency department 2 hours ago with anginal chest pain and ST elevation lead 1 ABL and V1 to V3. At the time, the interventional cardiologist on call was involved in a complex case and was unable to take the patient for prompt primary percutaneous coronary intervention. Thus, tissue plasminogen activator was administered. However, 120 minutes after administration of the tissue plasminogen activator, the patient continues to complain of chest pain, and his ECG shows no resolution of ST segment elevation. What is the next most appropriate step? Okay, so A says administer a second dose of the tissue plasminogen activator. B, administer tryptophanase 1.5 million units over 1 hour. C, proceed with urgent coronary artery bypass grafting. D, proceed with urgent percutaneous coronary intervention. And E, wait for 60 more minutes before pursuing any other therapeutic options. Okay. So we'll go through a few points and then we'll come back to the question to answer. So this patient has evidence of failure of reperfusion with fibrinolytic therapy due to the persistent chest pain and ST elevation after 90 minutes. In this case, rescue percutaneous coronary intervention should be pursued, and repeating a second dose of tissue plasminogen activator or a different fibrinolytic is not warranted and can be potentially dangerous. And coronary artery bypass grafting is not warranted prior to knowing the anatomy. And in the immediate setting after administration of fibrinolytics, it carries an exceedingly high risk of serious hemorrhage. Failed thrombolysis in STEMI patients is a challenging problem and can be treated with a variety of strategies. And some of the key points to note is that a failed thrombolysis is defined as a less than 50% ST elevation resolution after 30 minutes of giving the thrombolytic therapy. And failed thrombolysis or thrombolysis is a predictor of in-hospital or post-mortality in ST elevation MI patients. And rescue PCI with coronary stenting is often the preferred treatment for failed thrombolysis. And this should be done in a timely manner by an experienced center. FT segment resolution is usually a useful marker of successful thrombolysis and can help identify low-risk patients for early discharge. And patients with acute ST elevation myocardial infarction should receive coronary perfusion therapy with either PCI or thrombolysis. And for most patients with acute STEMI, PCI is preferred over fibrinolysis. However, fibrinolytic therapy should be used if primary PCI is not available. Okay, so I'll give a few more information. So we'll look at some indications for thrombolysis as well as contraindications. So all patients with STEMI who cannot receive primary percutaneous coronary intervention should, in a timely manner, should be considered for immediate fibrinolytic therapy. And some of the absolute contraindications include intracranial hemorrhage, known structural cerebral vascular lesion, known malignant intracranial neoplasm, ischemic stroke within 3 months, suspected aortic dissection, active bleeding or bleeding diathesis, or significant closed head injury or facial trauma within 3 months. Again, also look at what one should do when a patient presents in terms of the timelines with ST elevation MI and the algorithm to follow. So if you have a patient who presents with ST elevation MI and the duration from the onset of the pain is up to less than or up to 12 hours, we need to consider whether the patient can undergo PCI within the first 2 hours or the first 120 minutes of first medical contact. And if this is possible, then we need to perform immediate PCI. And the goal is to perform a PCI within the first 90 minutes of arrival at the hospital. However, if it's not possible to perform a primary PCI within the first 120 minutes, then the patients will need to receive fibrinolytic agents if it's available. Okay. So if the fibrinolytic agents can be given, then it should be done immediately, after which patients should be transferred for angiography. However, if it's not possible to give the fibrinolytic agents, then a PCI should be performed as soon as possible. Again, if patient presents with ST elevation MI and the duration of the duration from onset of the chest pain is more than 12 hours, but it's less than 48 hours, we need to consider whether there is evidence of ongoing ischemia. And if the answer is yes, that there's an evidence of ongoing ischemia, which may be characterized by ongoing chest pain, then PCI should be performed as soon as possible. However, if there is no ongoing ischemia, no evidence showing ongoing ischemia, then a non-urgent PCI should be done if available. However, if it's not available, then management without PCI or fibrinolysis should be considered. Lastly, if patient presents after 48 hours of the onset of the chest pain, then the approach to reperfusion should be individualized. Okay, so back to the question 134. The correct answer will be D. We should proceed with urgent percutaneous coronary intervention. Okay, so 135. Mr. Cooper underwent tissue plasminogen activator administration for acute ST elevation myocardial infarction 1 hour previously. He had an excellent response with resolution of his ST elevation and chest pain. However, the nurse pages you to evaluate a change in his rhythm. You note a wide complex ventricular rhythm with a rate of 75 beats per minute. Mr. Cooper continues to feel well without new symptoms, and his blood pressure is 120/80 millimeters of mercury. The next most appropriate therapeutic maneuver is switch of the following. So A, administer amiodarone 150 milligram IV over 10 minutes. B, administer plecanide 400 milligram orally. C, administer metoprolol 5 milligram IV every 5 minutes for 3 times. D, carotid massage, and E, continue observation. Okay, so this patient has an accelerated ventricular rhythm, and it's a common finding in patients with successful reperfusion after thrombolytic therapy. And the proposed mechanism is enhanced automaticity of ventricular pacemaker, although triggered activity may play a role, particularly in ischemia and also digoxin toxicity. Okay, so it's idioventricular rhythm is classically seen in the reperfusion phase of acute MI, and is usually a well-tolerated benign self-limiting arrhythmia and requires no further therapy. It invariably resolves on its own and is also known as accelerated ventricular rhythm. And it resolves when the rate of ectopic ventricular pacemaker exceeds that of the sinus node, and is often associated with increased vagal tone and decreased sympathetic tone. Plecanide is a class 1C antiarrhythmic. It's not recommended for patients with ischemic heart disease, structural heart disease, or previous myocardial infarction, and proved inducible ischemia. It was found to increase mortality in the CAST trial. CAST trial is cardiac arrhythmia suppression trial, and plecanide should not be used, otherwise it's contraindicated in patients with depressed ejection fraction and may worsen congestive heart failure in these patients. Again, amiodarone or metoprolol would be appropriate therapy if this was a ventricular tachycardia or supraventricular tachycardia. And carotid sinus massage would be appropriate in the setting of supraventricular tachycardia. So what are some of the ECG features of accelerated ventricular rhythm? Usually the rhythm will be regular, and the rate is typically between 50 and 120 beats per minute. There may be 3 or more ventricular complexes with each PRS duration being more than 120 milliseconds. There are a number of causes, and the most common is during the reperfusion phase of acute myocardial infarction. It can also be caused by beta sympathomimetics, such as adrenaline. Drug toxicity can also cause it, especially digoxin and cocaine. It can also be caused by electrolyte imbalance, cardiomyopathy, congenital heart disease, and myocarditis. Its management usually does not require treatment and is usually self-limiting. Okay, so back to the question. The next most appropriate therapeutic maneuver for these patients would be to monitor the patient since it's usually a self-limiting condition. Okay, so thank you very much. This is my last question.
Okay, thank you so much, Dr. Ofosu, for coming up to take your parts. Okay, so the next person to present is Dr. Kofi Asamoah. Is Dr. Kofi on the call?
Okay. Good evening, everyone. Please, if you don't mind, let me make further clarification to the question I answered, the last question before the next person takes over. The one about the commonest malignancy. Okay, I've tried to look through. Can you hear me, please?
Yes, I can hear you.
Yes, I've tried to look through, and the sentence about the commonest malignancy or commonest metastatic tumor to the heart being melanoma is currently not correct. That is wrong. That statement was correct as far back as 2018. So the current teaching now is that based on percentage, the commonest now is lung cancer, 30 to 40%. Breast cancer is the next, 20 to 30%. Lymphoma, 10 to 20%. Then melanoma is number 4, 5 to 10%. Then the 5th is kidney malignancy, 5 to 10% also. So, but the question is correct based on the options that we are giving. So,
that was
on the basis of the
time.
options that we're given in that question, melanoma is the correct. No, even now. That's question 110. Question 110. Let me see. So, based on the options that we are given, the commonest based on those options that we are given is malignant melanoma.
Why not the small cell lung cancer?
Hello?
I was saying, why not the small cell lung cancer that was in that option?
Okay, I'm not even seeing the option. So if lung cancer is there, then that's the correct option. Because I'll post this thing now. The commonest is lung cancer.
Okay.
Yeah, the last
Second,
option in
breast.
that question was small cell lung cancer.
Okay, so that is lung cancer. So that should be the correct option.
Maybe we can I make a comment? I think we came across something like this in a wrong world. And I think looking up, yes, I think what was stated there was that the most common malignancy that metastasizes to the heart is one lung cancer. They put a percentage of 36 to 39%, followed by breast cancer and hematologic malignancies. But there was also another about malignant melanoma. They said, okay, cardiac metastasis is typically involves the myocardium and pericardium, rarely affect the valves and endocardium. Then many cardiac metastases are clinically silent. For example, malignant melanoma, and they said 28 to 56% of patients with malignant melanoma have metastasis to the myocardium or pericardium.
Okay. The understanding I have from what you've read is that the chance melanoma has high chance of metastasizing to the heart. However, when you compare with other malignancies, okay, the commonest that is seen is lung cancer, because obviously lung cancer is commoner than melanoma.
Exactly.
So lung cancer, because lung cancer is commoner than melanoma, that is the one you will likely see in the heart. But if somebody has melanoma, the chances that it will go to the heart is higher than, I don't know whether I'm making sense. If somebody has melanoma and somebody has lung cancer, melanoma will likely go to the heart more compared to the lung cancer. That's the understanding from what you said. But looking at, as in generally, the commoner metastatic malignancy seen in the heart is from the lungs. Obviously, because we have more lung cancers than melanoma. I think that's what I understand. Okay, thank you.
So in essence, the answer is what? Lung cancer, right?
Yes,
okay, small
lung
cell.
cancer.
Okay, thank you so much. All right,
Yeah.
so Dr. Asemoka is not on the call, and I just realized that coincidentally I put Dr. Maduka's name there, and Dr. Maduka has just taken a part, so I'll have to come in here. I mistook. I call you. I know you as Maduka. I don't know you as Okorafo. So I'll have to take this part. Okay, so we'll go to number. What number is that? So, sorry, please let me just locate the particular number. Okay, Dr. Conte, okay, you can go to number 141 to 145. All right, so 141 says, all of the following statements regarding epidemiology of hypertension are true, except A, amongst individuals aged 60 years or older, average systolic blood pressure is higher in women. That is actually true. You understand? Over when they get older due to deficiency in estrogen and all, so most times their systolic blood pressure gets higher as compared to when they are younger. So yes, that option is true, but we're looking for an except option. So B says the systolic blood pressure increases steadily with age throughout life. That's actually false. So when individuals are greater than, or when individuals are less than 55 years of age, their diastolic blood pressure increases. But after then, the diastolic blood pressure reduces. So it's not increased all throughout life. So after 55 years, the diastolic blood pressure is set to reduce. Okay, so we are looking for the except option. So that's actually a false option. That's actually false, meaning that is the true option. So now going to see hypertension prevalence is longer in Mexican Americans than non-Hispanic whites. That's actually we're looking for the false answer, right? Okay, so that's actually true. So the Mexicans actually have the prevalence of hypertension of about 28.9%. And then the non-Hispanics, their blood pressure is about, and the prevalence of hypertension is 33.5%. So they are saying that the Mexican Americans have a lower prevalence of hypertension as compared to the non-Hispanic whites. So that's actually false, meaning that that's actually true, but we're looking for a false option. Then D says, in industrialized nations, blood pressure increases steadily during the first 2 decades of life. Yes, that is true. So in industrialized nations, in the first 2 decades, it's been noticed that blood pressure increases steadily in the first 2 decades of life. So that's true, but we're looking for the false option. Okay, so E says, in the United States, approximately 30% of adults have hypertension. That's actually true, but we're looking for the false option. So the false option is actually B, which says that the absolute blood pressure increases steadily with age throughout life. No, it's in the first 55 years of age. And then after then, the absolute blood pressure declines. So B is the right answer for 141. So I don't know if we have any contributions to say about that particular question. Otherwise, I go to 145. So disease of which organ is the most common cause of mortality in hypertensive patients? Okay, so basically, hypertensive heart disease has been said to be commonly seen in hypertensive patients. And then, if not well taken care of, it progresses to heart failure. And heart failure has said to be the commonest cause of mortality amongst hypertensive patients, then seconded by stroke. So now they're asking, disease of which organ is the most common cause of mortality in hypertensive? So it's actually the heart, due to heart failure, which is the commonest cause of deaths amongst hypertensive, then seconded by stroke. So the answer there is B, which is heart. Then if they're asking for the second, then it will be the brain. But they're asking for the most common, so heart is the right option there for 142. Then 143. A 28-year-old woman has hypertension that is difficult to control. She was diagnosed at age 26. She was diagnosed at age 26. Since that time, so she has been on increasing amounts of medications. Her current regimen consists of labetalol, 1,000 milligrams twice a day, lisinopril, 40 milligrams once a day, clonidine, 0.1 milligrams BD, and amlodipine, 5 milligrams daily. Okay, so on physical examination, she appears to be without stress. Her blood pressure was 168, 100 millimeter of mercury, and heart rate is 84 beats per minute. Cardiac examination is unremarkable without rubs, gallops, or murmurs. She has good peripheral pulses and no edema. Her physical appearance does not reveal hirsutism, fat maldistribution, or abnormalities of genitalia. Laboratory studies reveal a potassium of 2.8 milliequivalents per deciliter, which is low, showing this patient is hypokalemic, and a serum bicarbonate of 32 micro equivalents per DL, which shows this patient has metabolic alkalosis because the bicarbonate is increased. Then the fasting blood glucose is 114 milligram per DL. That's actually normal. So what is the most likely diagnosis? Okay, so A says congenital adrenal hyperplasia. So all of these are secondary causes of hypertension, but we want to know which of them has hypokalemia and metabolic acidosis associated with it. Okay, so congenital adrenal hyperplasia, yes, it's commonly seen in the young females, but they don't present with hypokalemia and metabolic alkalosis. So that rules it out. Okay, so B says fibromuscular dysplasia. Fibromuscular dysplasia, yes, is a common cause, is a cause of one of the secondary causes of hypertension, but they don't have the features of hypokalemia and metabolic acidosis. Cushing's syndrome can also cause, is a cause of secondary hypertension, but there's no glucose intolerance. If you notice, the fasting blood glucose is normal, and then she has no form of fat maldistribution, and then there's no problem with the genitalias and all. So that actually ruled Cushing's syndrome out. Then D says Cone syndrome. Another name for Cone syndrome is primary hyperaldosteronism. So we all know that with increased aldosterone, it causes hypokalemia, and that brings about what's metabolic alkalosis. So that's Cone syndrome. Cone syndrome is because of secondary hypertension associated with hypokalemia and metabolic alkalosis. So that makes D right. Then E says pheochromocytoma. Yes, it's a cause of secondary hypertension, but there's no history of palpitations, no headaches, no excessive sweatings, no episodic symptoms. So that's actually ruled pheochromocytoma out. And then pheochromocytoma is not associated with hypokalemia and metabolic alkalosis. So that's why D actually stood out from the causes of secondary hypertension in this secondary cause of hypertension in these patients. Okay, so I'll go over to the next option, 144. What is the best way to diagnose the disease in the patient described in what we just talked about? Meaning that how do we make diagnosis of patients with primary hyperaldosteronism? So A says renal vein renin levels. You know, this patient is already on an ACI. Patient is on lisinopril, so it will give us a false picture because it would give us a falsely elevated renin. So that the true picture in this patient who has Cone syndrome. So that rules it out. Then B says 24-hour urine collection of metanephrine. That's actually used in making diagnosis of pheochromocytoma. And this patient doesn't have pheochromocytoma. Then C says MRI of renal arteries. This patient doesn't have renal artery stenosis, so that rules it out. Then D says 24-hour urine collection for cortisol. This patient doesn't have Cushing syndrome, so that rules it out. So the right option here is E, which says plasma aldosterone renin ratio is the right answer. And it's expected that it's done by 8 a.m. in the morning, and it's expected that they will have a ratio of 30:50. So that's actually what we see to make the diagnosis of patients who have Cone syndrome. So the right option there is E, that's plasma aldosterone renin ratio. All right, so going over to 145, which says Mr. Milkins is a 65-year-old aeronautic engineer who has never been to the doctor and takes no medications. He is brought to the emergency department by his wife for worsening headache over the last day and confusion starting about an hour ago. His blood pressure on presentation is 230-140 millimeter of mercury, and his heart rate is 90 beats per minute. Arterial oxygen saturation is 95%. On examination, he's moving all extremities equally, and there are no obvious deficits in his cranial nerve function, but he's clearly delirious. Cardiac examination reveals an enlarged and forceful point maximal impulse. That means the apex beat is actually displaced. And then also has an S4 gallop reading. So already we know this patient has a hypertensive heart disease already. There's already a target organ damage. His lungs are clear to auscultation. Laboratory studies show creatinine of 2.4 milligram per DL, which is quite slightly elevated, and then proteinuria of 2 pluses in the proteinuria of 2 pluses and hematuria. And then he also has hematocrits of 32% with normal platelet count. You examine his peripheral blood smear. Okay, his peripheral blood smear actually revealed schistocytes. Emergency brain MRI shows old microvascular changes, but no acute infarcts of hemorrhage. So regarding his blood pressure management, which of the following would be the best reasonable therapeutic cause? So this is just a patient who has hypertensive emergency. Why? Because he has target of organ damage. He already has a problem with his heart. He already has problem with his brain. He already has the what we call the watershed microinfarction. And then he also has picture depicting with called hemolytic anemia. He already has hemolytic anemia, but more or less what we are concerned about is his kidneys, and then also his heart, and then his brain. So already has a target organ damage here. So now, how do you manage a patient with hypertensive emergency? So basically, we are aiming at bringing down the mean arterial pressure by 25% in the first few minutes to hours. And the way we have to bring that down is by giving parenteral route of IV antihypertensive
And the best here that we can give that is of IV or parenteral route is the labetalol, which says that we give 20 milligrams of IV labetalol and initiation of a continuous parenteral drip of gold mean arterial pressure of 125 millimeter of mercury in the first hour. So as I said earlier on, the aim is to bring down the mean arterial pressure by 25% in the first minutes to hours. So that's why C is right. Others are actually given through oral routes, and that's not what we need at this point in time. Then for E, that says emergent plasma apheresis. If it was a case of thrombotic thrombocytopenia, thrombotic thrombocytopenia, that's when we can actually give a patient do emergency or an emergent plasma apheresis. So that's actually what will take care of the blood pressure, but that is not the case scenario here. So that's why E was ruled out. So the answer here is C, giving IV labetalol in a patient who has hypertensive emergency, how to manage it at that moment. So thank you. I think I'm done with the session. Don't know if we have anything to say. Okay, so the next person to present is Dr. Sani. Is Dr. Sani here? Okay, so you can have the floor. Thank you.
Hello, good evening.
Yeah, good evening.
Yeah, am I audible?
Yes, you are very much. Thank you.
Okay, I'm to answer question 146 to 150. Okay, question 146. Which of the following statements regarding the physiology of renal perfusion is true? Physiology of renal perfusion. So A, due to tight precapillary regulation, the glomerular capillary endothelium is relatively shielded from pressure injury. B, renal cortical blood flow is less than renal medullary blood flow. And coupled with the high metabolic needs of renal cortex, this leaves the region borderline on hypoxia. C, renal perfusion is tightly regulated to metabolic needs of the kidney, and that the urinary albumin excretion is predictive of systemic atherosclerotic events and can present years in advance clinical atherosclerosis. And E, venous blood returning from the renal cortex has a lower oxygen content than venous blood returning from the renal medulla. So the first option, yes, the glomerular capillaries have tight precapillary regulations. And when I searched through the literature, this anatomy, this is a form of compensatory mechanism that provides a relative protection, not absolute, to high pressure conditions like hypertension and then oxidative stress. But that does not prevent, so these are temporary measures. But ultimately, if the pathology persists, patients can ultimately develop complications from those factors. So looking at the option, in the book, the answer is false. But actually is one of the regulatory mechanisms, renal auto-regulatory mechanisms that the kidney devise to form a form of protection to high pressure areas, hypertension and other conditions. So the renal cortical blood flow is less than renal medullary blood flow, and coupled with high renal metabolic needs. So this one, the renal blood flow about 70 to 80% of renal blood flow. 80 to 90% of renal blood flow actually goes to the cortex, and then only 10 to 20% goes to the medulla, and it's usually post glomerular service, the same blood that passes through the cortex, through the glomerular capillary networks that exit through the efferent arteriole. So the volume, the flow is less compared to the renal cortex. So this answer is false. And also the oxygen tension too is also less compared to the blood in renal cortex. The renal perfusion is tightly regulated to metabolic needs of the kidney. This is a first statement. There are several regulatory mechanisms. It include the renin-angiotensin-aldosterone system, and then the sympathetic stimulation. So it's not dependent on the metabolic needs of the kidney. So it's a first statement. Urinary albumin excretion is predictive of systemic atherosclerotic events and can predict and can present years in advance clinical atherosclerotic disease. Now, this is a true statement. It has been found that urinary albumin excretion, increased urinary albumin excretion, can predict, can be the first marker in systemic atherosclerotic events. It could be the first marker before the in atherosclerotic disease before the manifestation of atherosclerotic events. So this is a true statement. And then E, venous blood returning from the renal cortex has a lower oxygen content than venous blood from renal medulla. This also causes, like I said, majority of the renal blood flow is at the cortex, only 20% at most to the medulla, and usually is the post that's the post-glomerular circulation from the, so it's only 20%, and the oxygen concentration is lower in the cortical circulation, the medullary circulation than the cortex, the one that is at the cortex. So this is false. So I don't know, based on the answers, C is the most appropriate answer that is true. However, like I mentioned, when I searched through the literatures, as part of the compensatory, some of the compensatory mechanisms, the tight precapillary regulation have some relative shielding from pressure increase. So I think looking at this, C is D is the most appropriate option here. So like I said, I don't know if it is a recent finding, but I think I will post it on the group so that the precapillary, tight precapillary regulation has a role in some protective mechanisms. So I welcome contribution from participants before I move to the next question.
So sorry, what did you say about B, option B?
D is
yes,
is it D or B?
And then I said, what did you say about option B?
Okay, option B is false. What I said is that this one is speaking about that the renal cortical blood flow is less than medullary blood flow. So the cortical blood flow is the highest. It accounts for about 80 to 90% of renal blood flow. And then the medullary blood flow accounts for about 10 to 20% of renal blood flow. So this option is false, yes. So also the oxygen concentration is higher at the cortex compared to the medullary blood circulation. So that is what makes B and E false. Thank you.
Yeah, hello.
Thank you.
Hello.
Yes, I think this the issue with it is this tight regulation. So there is regulation of the renal blood flow by the precapillary, the afferent arteriole, but it is not tightly regulated because blood flow to the kidney is not just for the metabolic needs for the kidney alone, but in general to, get rid of waste product from the blood. So even though there is some regulation of the blood, but it's not, when they say it's tightly regulated, that is what makes that statement false. And then the same token also why C is also false. They say it's tightly regulated to the metabolic need. So there is flow for the metabolic need, but also a large amount of the flow going there is for removal of waste product from the blood.
Yeah, thank you. So, question 147. Which of the following statement regarding renal artery stenosis is true? A, an abnormally reduced renal artery blood flow velocity by Doppler ultrasound is predictive of hemodynamically significant stenosis. B, early in the course of renal artery stenosis, elevated systemic renin levels are typical. And C, in the general population, the presence of fibromuscular dysplasia is rare. That is less than 1% prevalence. And D, levels of renin activity observed in renal artery stenosis are predictive of response to medical therapy. And usually the first clinical presentation of renal artery stenosis due to fibromuscular dysplasia is reduced renal function. So renal artery stenosis, we know that about 70% is caused by atherosclerosis. And then about 20 to 30% is caused by fibromuscular dysplasia. And then other causes include Takayasu arthritis and also Aortic arthritis of the renal artery stenosis. So looking at the Doppler flow velocity, the narrower the lumen, the higher the flow velocity. So because the pressure will be high. So looking at option A now, an abnormal reduced renal artery flow velocity by Doppler ultrasound is predictive of hemodynamically significant stenosis. This is false, because it's been said that the increased renal Doppler flow velocity as high as 200 centimeters per second is predictive of significant stenosis, that is more than 60% stenosis of the renal artery. So a reduced renal velocity does not predict hemodynamically significant stenosis. So A is false. Then option B, early in the course of renal artery stenosis, elevated systemic renin levels are typical. Yeah, this is true, because it's been said that a significant number of patients that presents for renal donation with normal hypertension, normal blood pressure, tend to have, were incidentally found to have elevated renin level, and about 3 to 5% of these normal individuals turn out to have fibromuscular dysplasia, renal artery stenosis. So it will be the early sign of renal artery stenosis. So this is true. C, in general population, the presence of fibromuscular dysplasia is rare, less than 1% prevalence. So just like I said, that study that found elevated renin levels in normal individuals, the prevalence was found to be 3 to 5%, not less than 1%. So C is false. The levels of renin activity observed in renal artery stenosis are predictive of response to medical therapy. The level of renin activity is predictive of the severity or the significance of stenosis, and does not predict a response to medical therapy. So D is false. Usually the first clinical presentation of renal artery stenosis due to fibromuscular dysplasia is reduced renal function. This is also false. The first clinical presentation will be elevated renin, and they rarely cause renal dysfunction. So what they said is that they could cause elevated renin, and then they were found to be associated with renal artery aneurysm. Rarely, they can cause a reduced renal function. So, but as first clinical presentation, renal dysfunction is not the first thing to manifest with. So E is false. Thank you. Is there any other contribution on this question? Or I can move to 148.
Sorry, the answer is what? Sorry.
The answer is B.
Okay. Thank you.
Yes,
Thank
yes. You. Yeah. So question 148, a 75-year-old man underwent a diagnostic coronary angiography after an abnormal stress test. Arterial access was obtained easily in the right femoral artery, and the angiography was completed with 35 ml of iodinated contrast dye. Fortunately, no significant coronary stenosis were found. 7 days later, the man presents to emergency department with abdominal pain and nausea. He reports that his urine output has been poor recently. Examination reveals a slight fever, temperature of 38.3 degrees Celsius, and livedo reticularis on his lower extremities. Laboratory studies show a creatinine of 2.7 milligrams per DL, previously 1.1 milligrams per DL, white blood cell count of 10,500 per ml, with 21% eosinophils, and an elevated ESR of 92 millimeter in the first hour. What is the most likely diagnosis? So looking at the clinical scenario, this is an elderly man that had coronary angiography that was normal, and then had iodinated contrast dye injected. Now presented with, that was a week late, then presenting with fever, abdominal pain, nausea, livedo reticularis, eosinophilia, and elevated ESR. So all these options are possible differential diagnosis. Acute interstitial nephritis, arterioembolic renal disease, stroke, contrast-induced nephropathy, hypereosinophilic syndrome. But looking at the patient and the clinical scenario, the most likely diagnosis here is arterioembolic renal disease. If you look at the livedo reticularis, okay, and then the eosinophilia the patient had, and then the ESR and fever that the patient had. So, and then the preceding the femoral cannulation that the patient had during the angiography, that predisposed the patient, also in an elderly man. So that predisposed the patient to arterioembolic renal disease. So B is the correct answer. Acute interstitial nephritis, yes, they may present with eosinophilia, but here, ordinarily, we may have preceding history of, let's say, a drug interaction, which could be a trigger. Stroke syndrome, yes, that can present with eosinophilia, even the elevated ESR. But however, the patient may have some history of ATP and other forms of allergic reactions. So that is why looking at this clinical scenario, it doesn't really fit well compared to the option. Contrast-induced nephropathy, yeah, it can explain the drenched renal function. But ordinarily, we don't expect the patient to have fever and elevated ESR. So hypereosinophilic syndrome, yes, they can present with elevated ESR, eosinophilia. Usually, this is more of a chronic disease. Usually, part of the diagnostic criteria is that they will have persistent eosinophilia of more than 6 months, and then eosinophilia of more than 6 months. And then you have to exclude, they may have organ dysfunction. This could be renal, cardiac, and then you have to exclude other causes of hypereosinophilia. And then typically they may be associated with other conditions like myelodysplastic syndromes, and it may be idiopathic. So, but looking at this, these things started just within a week, and this patient has abdominal pain and nausea. So that is what, and then the fever and other things in an elderly patient. So that is what makes be the most appropriate option in this question. Thank you. Any contribution or clarification? Okay, question 149. With which of the following patients who present to an emergency department reporting acute dyspnea will a positive D-dimer result prompt additional testing for a pulmonary embolism? Okay. Patient who presents emergency department with acute dyspnea and a positive D-dimer will prompt additional testing for pulmonary embolism. So A 24-year-old woman who is 32 weeks pregnant. B, a 48-year-old woman with no past medical history who present with calf pain following prolonged air travel. Alveolar arterial oxygen gradient is normal. So C, a 56-year-old woman undergoing chemotherapy for breast cancer. And D, a 62-year-old man who underwent hip replacement surgery 4 weeks previously. And E, a 72-year-old man who had an acute myocardial infarction 2 weeks ago. So looking at these options, now we are looking at most of these patients, looking at the pregnant women, pregnant woman, the 50-year-old that has breast cancer, the 4 weeks post-surgery and recent myocardial infarction. All these patients ordinarily will have elevated D-dimer. So elevated D-dimer will not cause an alarm in this patient. But if you look at option B, this is a 48-year-old woman with no past medical history, and she presented with calf pain following prolonged air travel. And then, even though they say alveolar arterial oxygen gradient is normal. So if this patient presents with acute dyspnea and elevated D-dimer, this patient will require more testing for pulmonary embolism, because ordinarily, I don't expect this patient to have elevated D-dimer. And then with the calf pain and the prolonged travel, that makes it the correct option. So, and then the normal alveolar arterial oxygen gradient does not rule out pulmonary embolism. So all other options, the A, the C, D, and E, ordinarily will have elevated D-dimer. So B is the correct option. Thank you. Any contribution?
Hello.
Sorry, I didn't get the explanation.
Okay. So the explanation is that if you look at these patients, pregnant women, pregnancy is a cause of elevated D-dimer. You understand?
Okay.
So if a 24-year-old woman that is 32 weeks present with elevated D-dimer and dyspnea, that will not, that will not make you, just go straight to evaluate for pulmonary embolism. You have to look at other causes of dyspnea in this patient, because normally you expect elevated D-dimer in pregnant women. You understand? So if you look at option C, 56-year-old with malignancy too, and also surgery. D-dimer is a fibrin degradation product. So you see that in any thromboembolic conditions, any condition that will lead to injury or blood formation. So if you look at apart from the malignancy and pregnancy, post-surgery, it's been found that post-surgery, patients tend to have elevated D-dimer, and they say the peak, it peaks around 7 days and it continues for several weeks. So 4 weeks after surgery, this is 2-year-old woman that had hip replacement. Yes, we know that pelvic surgery is a risk factor for pulmonary embolism, but if you look at the D-dimer in this setting alone will not make you, subject the patient to evaluation for pulmonary embolism. You have to look at other things that will explain that. Then in the E option, 73-year-old who had a recent myocardial infarction, so just like the surgery, they are also they are likely to have persistent elevated D-dimer at this setting. So for this 48-year-old B option, that is normal, you understand, she presented with calf pain following prolonged travel, you understand. So if she presents with dyspnea and elevated D-dimer, ordinarily, she doesn't have anything to explain the elevated D-dimer. In a high-risk patient like this, with calf pain, prolonged history of travel, you have to evaluate the patient for pulmonary embolism. So that is what makes it the correct option. I hope it's clear.
Thank you. Yeah.
Thank you.
Yeah, thank you, Dr. Sani. Just a quick one. 149, I think we can just look at it as those ones have risk factors for pulmonary embolism, but the other one has actually the active symptoms, which is calf pain. Just a little recall to that option, to that question number 148. Why do you think that was not contrast-induced nephropathy? Sorry to drag you a little backward.
Okay. The contrast-induced nephropathy.
Yes.
Yeah. So why it is not contrast-induced nephropathy? Yes, if you look at the deranged renal function and the preceding history of the contrast, you see, yeah, it's a risk factor. But like I said, this patient has fever and elevated ESR, which will not be explained by contrast-induced nephropathy. You understand?
Okay.
Yeah. And also this patient has abdominal pain and nausea a week after this procedure.
Okay, a week.
Dr. Sani, should that patient also has levodo reticularis in that history, right? Because I'm seeing something like that.
Yeah, that's another, yes.
So in fact, that's just what gave it out.
Yes, actually, yes. The levodo reticularis
gives it out. In fact, I was just taking the picture here to remind myself. But then I was just looking at the pictures presented in the options. Levodo reticularis gave it out, no doubt.
Yeah.
But then we're talking about fever and the time lag between the procedure and the development of the symptoms, right?
Yes.
Okay. Okay. Thank you. Thank you.
Thank you. Okay. Question 150. A 42-year-old woman presents to emergency department with acute onset of shortness of breath. She recently had been to visit her parents out of state to ride in a car for about 9 hours each way. 2 days ago, she developed mild calf pain and swelling, but she thought that this was not unusual after having been sitting with her legs dependent for the recent trip. On arrival to the emergency department, she is noted to be tachypneic. Her vital signs are blood pressure 98/60, heart rate 114 beats per minute, respiratory rate 28 beats per minute, oxygen saturation 92% on room air, and weight of 89 kilograms. The lungs are clear bilaterally. there is pain in the right calf with dorsiflexion of the foot, and the right leg is more swollen when compared to the left. An arterial blood gas measurement shows pH of 5.2, partial pressure of carbon dioxide of 25 millimeters of mercury, partial pressure of oxygen of 68 millimeters of mercury. Kidney and liver function are normal. Helical CT scan confirms a pulmonary embolus. All of the following agents can be used alone as initial therapy in this patient except. So this is a clinical scenario of 40-year-old that presents with CT confirmed pulmonary embolism. So we are to look at the agents that can be used alone. So okay, that should not be used here because they said all can be used alone as initial therapy in this patient except. So looking at the anticoagulants, they said enoxaparin 1 milligram per kg subcutaneously twice daily, fondaparinux 7.5 milligrams subcutaneously daily, enzaparin 175 units per kg subcut once daily, unfractionated heparin, IV adjusted to maintain activated partial thromboplastin time 2 to 3 times the upper limit of normal, and warfarin 7.5 milligrams orally once daily to maintain international normalized ratio of 2 to 3. So this is straightforward. The answer is E. It's only warfarin that should not be used alone as initial therapy. Reason being that you know that warfarin is inhibits vitamin K dependent clotting factor. So it inhibits the synthesis of vitamin K dependent clotting factors. That is the mechanism through which it exerts its anticoagulant effect. So in addition to the vitamin K dependent clotting factors, there are other endogenous anticoagulants that are also vitamin K dependent, which are also inhibited by warfarin. And these are the proteins, protein C, protein S, and antithrombin 3. All these three play a role in endogenous anticoagulation. So if warfarin inhibits both the synthesis of those protein factors and these endogenous anticoagulants, and these endogenous anticoagulants have a very short half-life compared to the clotting factors. The half-life of the clotting factors is around 5 to 7 days, while those endogenous anticoagulants, like protein C and S, is usually in hours. Protein C is about, the half-life is around 6 to 8 hours. Protein S is around 12 to 15 hours. Then there is only antithrombin 3 that the half-life is a bit longer. That is 2 to 3 days, about 2 to 3 days. So if you look at it, the first effect will manifest on the indigenous anticoagulation. That is one. And also the anticoagulant effect, because of the longer half-life of the clotting factors compared to the endogenous anticoagulant, the effect usually manifests within 5 to 7 days. So that is why warfarin has initial procoagulant effect. So for that reason, it is not recommended for warfarin to be used alone as initial therapy. So you have to compare. You have to either start with heparin. You know, when the INR is around 1.5, then you introduce warfarin, or you start concurrently the warfarin and the heparin, and then discontinue the heparin after 5 days, or when the INR is 1.5. So that is what why E is the correct answer here. Thank you.
Or Dr. Sani, another way to look at it, can we say that at that initial time, it should be given with enoxaparin the first 3 to 5 days, maybe due to the coagulation states. You understand? It's pro-thrombotic in the first 3 to 5 days. Like you cannot give it alone, you have to add on. Can we see it in that way too?
Yes,
Okay.
you can either start the two concurrently, or you start heparin first, and some will say you discontinue you start first when the INR is 1.5, then you continue your overlap for like 48 hours and then discontinue. So either way you can.
Okay. Thank you. Thank you. Somebody wanted to say something. All right. Okay. So we'll move over to the next.
That's the end of my part.
Okay. Okay. Thank you. Thank you so much, Dr. Sani, for coming in. We appreciate your effort. Thank you. All right. So the next person, Dr. Irabo. Oh, where's Dr. No, he's not Dr. Irabo. Dr. Ozo. Okay, Dr. Ozo is not here, and Dr. Irabo is supposed to be the backup. Dr. Irabo. Dr. Irabo is not here. Okay, I'll call him. All right, so the next person is Dr. Awodi. Dr. Awodi, I thought I saw Dr. Awodi here. Dr. Awodi, OPO2. Dr. Awodi, OPO2. Dr. Awodi, you're the next.
I'm even thinking whether those questions were answered yesterday, sir.
No, the two last questions, no, they were not answered. They're the two last questions, are like the last batch of the questions. Dr. Awodi, sorry, Dr. Ojo, please help me call Dr. Irabo. Please go and wake him up, please, sorry. Dr. Awodi? Okay, so the backup person for Dr. Awodi is Dr. Brown, and it's Dr. Brown here. Hi.
Chief,
Okay,
I'm
Dr.
here,
Brown
but
is here.
sorry, I didn't check it though. Sorry.
Okay, so okay, let me call. Okay, just a minute, please. Let me just call. Sorry, just a minute.
Dr. Allison, are you still there?
Yeah, Dr. Kobe.
Okay. All right. Hold on. How's it been? Sorry, I stepped out a bit.
Okay.
We're going on fine, right?
Yes, we are dancing. We're moving.
Okay. Okay.
Yeah.
We aim to finish the book today, right?
Let's see.
Okay.
Oh, people are sleeping.
All right. Yeah, it seems Dr. Woody has slept off and there are boys not even around.
Okay. Okay. Whether Dr. Brown, Dr. Brown, whether you just come in like that. Anyhow it goes.
Dr. Brown, can you take it? Bishop. Hello, Bishop. Bishop is not around. All right. I think he has left. And Dr. Florence, who are the other backups that are on the call?
Okay, Dr. Brown is supposed to be the backup for the last question. And Dr. Irabo is supposed to be the backup for the other one. Or maybe we just...
Dr. Brown has left. Maybe we can take them tomorrow. It seems he's not well prepared.
All right. All right. Okay, so I want to thank everyone, the presenter, the first presenter, thank everyone who took their parts today, and especially thank our chiefs for their consistency and their show of love towards us. So in the absence of further contributions and questions, I'll hand over the class to my chief, Chief Okopi. Thank you.
Thank you so much, Dr. Florence. Thank you, Dr. Conte. And thank you for everyone for taking your part. Thank you, Dr. Jeremiah in absentia, for that lucid presentation. Please, let's just keep the fire burning. It's quite exciting the way we're going. We're covering a lot of grounds, and I'm very positive that this badge we're going to have very good success. In the absence of further announcements or any other stuff, I think we can meet tomorrow morning and then later in the. Thank you so much, Dr. Allison. I saw you today. I was so pleased and I saw your contribution. Thank you, Dr. Conte. Thank you, everyone, for the commitment. Thank you. God bless.
Okay, so tomorrow we'll be having, anyway, I'll get back to you. All right, later. Thank you.